because this is sort of an unprecedented story where the premiers say we're going to endorse guidelines. You know, what's the real possibility here? You've got potentially narrowing down to a small number of guidelines from the entire cardiovascular community. Can we do something with this? How would Tom pick this up? And I'm going to come back to him in a minute.
Yeah, so we were joking around already this morning.
Okay.
You see, because it's a nice thing that the premiers now have pressure to actually announce something, you know, in 2 to 3 years. That you know, there's some follow-up to all this, and so a number of provinces are actually very motivated in this. And so I think what we want to do is, in fact, roll out a number of the tools. And the question is where, you know, there may be different opportunities in different provincial environments. You know, how we can do this. So Ontario is very interested in electronic health record implementation. You know, when talking about Alberta, is their chronic disease strategy, and this is definitely will involve the primary care, you know, sort of a community in which we talk about very much. And so we want to actually start out with by moving some process indicators. You know, so we're developing quality outcome indicators in which we can track. But of course, you know, down the road, what we really want to do is actually see that impact on more hard endpoints like you know, hospital complication rates, you know, patient being admitted to a hospital, and those type of indicators.
Thank you. Tom, I mean, is it possible to have a kind of a guidance document that is not contextualized, or is it agreed to by people across the country that would have some value as you roll out your clinical networks?
Well, at one level, you could say that top-down clinical practice guidelines are really, truly wrong-headed. I don't see that in Sea Change. I think this has really been clinicians and researchers getting together to synthesize a huge volume of content that's been developed over the last really 25 years and distill it down into something we can do something about. But even so, now what can we actually do with these many recommendations? Whatever we do, it needs to be visible, it needs to be doable, and the public has got to get it. So I think the kinds of things that we might cherry pick out of here that give those kind of characteristics. We're keen on enhancing blood pressure monitoring by pharmacists when people walk into their drugstores and get their prescriptions, kind of thing. We think we want to start adopting a few healthy organizations in the province that actually take on Sea Change as a corporate initiative. One of the big oil companies, and maybe even Alberta Health Services could become a heart-healthy organization, stuff of that sort. So we need to pick away at the details. We now got the structure, we got motivated clinicians, we got the incentive programs in place, so we need this type of material actually to work with.
Thank you. Carol, cancer is a little different. Do you want to comment on the idea of trying to get to common guidance or finding some way of moving to common standards in the way care is practiced?
You mean on a national basis?
Yeah.
Yeah. Well, I think that this is already happening. I think that historically, because cancer was well organized within each province, several provinces developed their own guidelines processes or their review of evidence to develop practice guidelines. And they didn't always actually match up from province to province. But I think there have been a couple of things that have happened recently that have led to a big change. The first is the National Drug Review Program, where the basis of this is now a national review of the clinical evidence. And it's the review of the evidence and the health technology assessment that then results in a recommendation that should stand across the country. Now, those are early days, but I think there's a signal of people recognizing that the evidence is the evidence, and while the application of it might need to be contextualized, the actual analysis of the evidence and the recommendation should be pretty uniform across the country.
Can I just make a comment on that, Terry? Mm-hmm. You know, the cancer world has been organized for a long time, as has been said. But a lot of the organization is about cancer chemotherapy protocols and radiotherapy protocols. So the kinds of things we are doing in cancer is not focused on stuff like that, but more the models of care associated with cancer. Right. You know, most cancer surgery is done by general surgeons. As soon as you cross that divide, you get into all kinds of complexities and trade-offs, and you know all about that, right? So the time it takes from the point that you first notice an abnormality on your chest x-ray or a cough with a little hemoptysis till the time you get an actual diagnosis and treatment in Alberta is too long. So that's one of the things we're focusing on now, trying to get the time from the first diagnosis to definitive therapy down to, really a matter of days and weeks from what it has been in months. Or the prostate cancer thing and all of the fussing about PSA testing. What's the role of PSA testing? How frequently should do it after you've been diagnosed as having real prostate cancer? Because that test is out of control on that end too, not just the front end. So the cancer world, if we can't be successful in the cancer world, we can't be successful anywhere.
Thank you. Questions? Shalom, you have the first response here.
I've been listening to a lot of this, and it's really interesting. It's interesting, especially in the light of what the last speaker said. I mean, the kind of description that he had of neonatal care and how actual practice can make a big difference to how you think about things. I think that one of the things that's happened in the Patients Association is that we've been given lots of sets of guidelines and plans to look at and to see whether or not and to what extent they're actually patient-centered. And largely when guidelines or pathways or even networks are created by providers alone without any patient input, there are lots of aspects of the patient experience that are just excluded, just aren't thought about. And it's not a matter of ill will. It's a matter of not having people there who can sort of present that side of things. So you have, and much of the conference today has had small aspects of that, where we go one way and we say patients really have to be involved and things have to be patient-centered. We want them to be patient-centered. And yet the actual patient being there and being a participant in the development of the guideline or the development of the pathway, or being able to even look at the pathway or the guideline or the network and think about it from the patient perspective, really is only beginning to happen. And I would urge you to recognize that and to begin the process of including more patients in the processes that you're engaged in so that you get the actual patient perspective and the patient view of many of the things that you're trying to do. I noticed that in the cancer care example, the pathway that's being developed that can be understood by patients is very difficult to do and will take some effort. And it looks like it's not even clear that it's going to be able to be done. So I say, good on you that you're trying, but there's a lot more effort that has to be made.
So put the patients at the table when the pathways are being developed and implemented is a key part of that without any doubt whatsoever.
For C-change implementation, working with, for example, Heart and Stroke Foundation, and many of the volunteer-driven organizations, in which they have direct access to the patient population to provide feedback in terms of what tools work, what tools don't work.
Heart and Stroke sends their guidelines to us to review, and they are not very patient-centered by and large. So a lot of the stuff that's done is done by experts, even inside some of the sickness organizations, and that should be known as well.
For the people in New Zealand that have had a lot of experience with this, we've partnered with them, and their approach to the dissemination of guidelines is use every mechanism known to man and beast and make sure that there's always a patient translation type version. So our approach to that is going to be all clinical care pathways will have a patient care pathway that aligns to it and is in essence a takeoff of that is easier to read and understand, and those will all be available on HealthLink. So the call-up line that you have after hours for getting physicians will all have the patient care pathways available to them so they can phone up and find out what their pathway is.
We have one or two here. Can I take both of them in a row and we'll ask the panel to respond? Marie-Dominique and Ingrid.
Take a microphone. Whoop-a-lay. Excuse me. So I'd like just to share a few thoughts and maybe some concerns, but I certainly don't want to appear negative. And I'm going to be the primary care advocate here. And what I'm struck by, I understand very well the need for those pathways, but to me it's a little bit back to the disease management approach. And I just want, because we were asked about, I was asked about how can we really have this primary care system going on. And I think that what is really the characteristic of primary care, and primary care providers, be them physicians, nurses, is that we are condition neutral professionals. And when we try to interact, certainly, with secondary care, we actually meet with those disease-specific or disease pathways. So, well, I recognize very well the need to really be well organized. And if I was a patient, I would be so happy to make sure that if I have a lung cancer, they will have a good lung pathway. So this is not being negative, but I think it is just to sensibilize all of you that if we have to articulate between primary care and also for those programs, so to think of the fact that the comprehensiveness, multimorbidity is really what's the approach and the condition-neutral approach for primary care. And I know certainly in the province of Quebec, in the Centre de Santé et Services Sociaux, in the CLSCs, you know the acronym, we are working more and more with professionals who actually are totally condition, I would say, free, and bring their expertise, our nurses and from all professions. So it's just a plea of thinking also of this kind of condition multimorbidity approach for the primary care when we try to work together. Thank you very much.
Thank you, Marie-Dominique. Go ahead, Ingrid, and we'll just have the panel respond.
I wonder if you'd comment a bit about how you communicate uncertainty around the evidence to both the providers and the patients. So in some areas you may have no data on frail older patients. For the risk of some drugs, it might be only a small sample of highly select patients. And so as I watch the Institute of Medicine reports, they're trying to think about how uncertainty around the evidence is better communicated to both patients and providers. So can you comment on how that will work in your guidelines?
Carol?
I could start with that. Maybe I could comment on just on the first point, which I think is really, really important, and the issue of how to integrate very complex disease-specific guidelines and make them work within a primary care provider's environment which has to be condition neutral. And we're certainly experiencing that with the pilot study of our electronic pathway solution, where it works really well for the nurse navigator, for the diagnostic assessment program. It works really well for the patient, whose main concern at that point is, do I have lung cancer? It's the family doctor who has to integrate it into the office setting. And I think that's going to be an ongoing challenge. But just to recognize that we've certainly flagged that. On the issue of the communication of uncertainty, there are many areas where there is either uncertainty or there are choices that need to be understood within the context of the values of the individual. And the vision that we have is that in the pathway, when there are specific areas where there is uncertainty, we just be explicit and state that, but try to give a little bit of a detail of why there is uncertainty. And where possible, develop decision support tools to enable patients and their practitioners to work together to try to come to the right decision for that individual patient that's consistent with their values. So that's the desired end state. I wouldn't like to suggest that we're there right now, but certainly there are decision support tools all along the way. There's lots of them available in cancer that could be embedded in a disease pathway.
Tom?
But let me also state the obvious. When there is uncertainty, sometimes you actually do have to do some more research. And so in that regard, we have a number of examples like that where we're working with Alberta government and Minister Horn's department. For instance, we're going to be introducing insulin pumps as a publicly funded service in Alberta in the near future. It's a decision that's been made, and the question is, how are we going to do it? Who should get them?
Right.
On what terms and conditions? And then who should keep them after some requisite period of time? Yeah, there is literature out there, but not all the kind of contextually important things that we need, particularly about continuation criteria. So what we're going to do in that regard is we're going to let that technology out of the bottle with access to it with evidence development and clear measures over the period of time. So we're not sitting here a year from now having introduced the pumps and not knowing what the hell we've accomplished as a consequence. So in the face of uncertainty, you have to be honest. But you sometimes also have to go and relieve yourself of the uncertainty.
Thank you. I'm going to ask you to thank our panel. They've been terrifically careful at keeping to time and very thoughtful. It's my pleasure then to introduce our last engagement for today, a different engagement entirely. And in doing this, I'm going to invite Eleanor Revoir and Andale McTavish to come and have a seat, and we'll have a chance to wire you up. Andale McTavish is the co-chair of the Patient Family Advisory Council of Kingston General Hospital, former English teacher, instructor, and she worked before in the standardized patient program, so she has a clear understanding about what it's like to interact in real life and in acting life with physicians. And Eleanor Revoir, we're delighted, is standing in as the Vice President of Clinical Administration and Professional Practice and Chief Nursing Executive, meaning she runs most of the hospital in Kingston, as I mentioned earlier today, because Leslie injured herself and was unable to join us. So Andale and Eleanor, we're in your hands. Thank you.
I'm going to begin, and I'd like to begin by thanking you for a very warm welcome, and I'm very pleased to substitute for Leslie. Any of you who know Leslie will know that it would have to be something very significant to keep her away from this sort of event, but she agreed to me sharing that over Christmas she had a bit of an injury when she was skiing, and so she's dealing with a pain issue, and it just really makes traveling impossible at this point. So I can promise you that could she be here, she would be here, but I'm very pleased to substitute for her. Typically at KGH, the patient voice is actually the first voice that anybody in our organization hears. At the point of hire, as we welcome learners into our organization, when we are doing community presentations about different initiatives. And we're very proud of that fact. So we're departing from script today in that I'm going to begin to speak first, but we thought it was important to be able to give the context for what we have been doing at KGH. And then we'll sort of have a little bit more discussion. As I say, we're approaching it a little bit differently because it is the context that helped us realize what an untapped resource that we had with patients and the families that we are working with in Kingston. KGH's journey began with a period of investigation and supervision about 4 or 5 years ago. Many within the Ontario system are very familiar with it. Others probably were because it was a bit of we were a lightning rod within the healthcare system for a while. We lost the confidence of our public, of our immediate community. We had very poor performance on a lot of the measures that should be predictably better. We had lost the confidence of our ministry. And so there was a very sharp awakening that change had to occur within our organization. We had to achieve a very substantial financial recovery as one of those pieces. It was approximately $30 million was set as the target that we had to achieve. And in doing it, we made a very clear resolve that in achieving that financial measure, we would not compromise patient care or quality. Arguably, some would say that we wouldn't compromise it anymore. And ideally that we would improve it and that we would improve the work environment for our staff. So that was the task before us. The work began with the recruitment, actually, of Leslie to the role as President and CEO, and in her work of building her senior team to guide the organization. It also began with the work of the board, and the board going through a refreshment and a learning again of the role of governance and the accountability of governance as it related to management. So you had a governance and management structure that we were actually going in the right and the same direction. When Leslie joined the organization, she, in her first 100 days, did a very close engagement with staff, but sort of a really quick review in that 100 days. But on completion of the 100 days, said these are the 5 areas that we are going to focus on within this organization. And everybody was set off with the resolve that these would be the things that we would work on. Immediately following began a more robust strategic engagement process and a strategic planning process. And in the course of that, there was consultation with over 1,000 staff within the organization and over 1,000 people within our community, be it the academic community, our healthcare partners, our patients, organizations that supported the community. And upon completion of that process, and after a validation with all who had fed this strategy and basically affirmed it was the right direction, the strategy was launched. While we were doing all of that, we were also getting patient feedback very directly through our patient relations program and in that engagement process. And we were hearing just how much we were failing our patients and community. We heard that they were afraid to come to our hospital, that they had concern about the safety, they had concern about the cleanliness, they felt disrespected and disregarded as they came into our organization. And so it was fortuitous as well that we had the opportunity to attend a Change Foundation session where Barbara Balick from the States attended, and she gave a message that was probably just perfectly timed to say that, you know, patient-centered care is not doing for and not doing to patients, which feeds all of our clinical and professional interests, but doing with patients. And that was a very significant turning point for us. And as we had patients give us the very horrible experiences, we also had patients who knew where we were going. They were willing to trust, and they came on board with us to be partners. And Andale was one of those individuals over 3.5 years ago. So I'm going to turn it over to Andale to tell you her story of becoming involved in what it means to be working in our organization. So Andale.
Thank you, Eleanor. Bonjour à tous et un grand merci de l'opportunité d'être ici avec vous aujourd'hui. 4 years ago today, I was admitted to the Kingston General Hospital to have a colon resection. I stayed 9 days, and I had absolutely no idea then how that 9-day stay would influence the course of my life. There was a lot to be grateful for in my experience. Hey, they took away my cancer. Very skilled surgeon, an attentive resident, excellent pain control, and generally adequate nursing. You'll notice a slight change in my tone when I say that. On the other hand, all those good things, the environment was dirty. The unit itself smelled unpleasant. I thought I would never get the smell out of my hair and clothes. Staff walked through the corridors loudly discussing a party last night. Very few people introduced themselves, and communication with my family was minimal. Although I wouldn't have put it in those words then, what I was longing for was someone to do something with me as a partner, not for me and not to me. Why come when I'm lying prone, open my legs without introducing yourself, and put white stockings on me? Why are you doing that? And what is your name anyway, and what do you do? Those were things I remembered even in my drugged stupor. During my stay in hospital, the hospital chaplain would come by frequently. I knew him socially, and I was, I suppose, quite verbal in my complaints or my description of what had gone on. He said, Andale, it's a perfect time. We have a new CEO, a new regime. It's a time for change. We're creating a patient family advisory council. Will you help us start it? At the same time, there was a person at my bed who said, I said to her, you know, I've heard there's a new CEO. Yeah, well, you know, it'll be like all the others. Nothing will get done. It's just the flavor of the month. Well, I'm glad to say I believe that this person was proved wrong. In February 2010, 3 patient advisors, myself being one of them, and 4 staff members were invited to create a patient-family council. We currently have 12 members that sit around the table as advisors once a month, and 4 staff who meet with us, Eleanor being one. But these 12 are a very small part of a much larger group of 59 advisors who are on every committee in our hospital that has anything to do with the care of patients. There is a patient at the table. As people have said before, that changes things. Our voices are helping transform patient care. We started very small. We had no template for how to proceed. All we knew is we wanted to do something. First thing we started off with was my pet peeve, because I was loud. I could not tolerate being in the hospital, being drugged, and having to look at people's crotches to find out who they were, and even then there were codes. So things would turn around, I couldn't see who people were, I had no idea. And moreover, I couldn't remember. So we designed something that could be worn in an appropriate part of your body that tells who you are and what you do. And what we found is something that simple promotes better communication, more transparency, and more respectfulness on the part of staff and patients. Staff have said they like it very much because they know who they're working with. We have many nurses and many staff on the floors at various times. We designed a new patient information booklet. That took months and months and months of hashing over. So templates were given to us and we changed them. Wherever we felt that they were not understandable or not representing the patient voice. We tested new menus. We advised on wayfinding in the hospital. We have an old hospital and it's very hard to negotiate your way around. So we looked at all those kinds of things. We helped eliminate rules with visiting hours. Now people can come and go whenever they want to. And people aren't afraid to leave because they know they'll be allowed back in. And so there aren't legions of people coming in at 2 in the morning, but if you need to stay there with a loved one, you're certainly not prevented from coming back. We've helped educate over 2,000 staff members on patient-family-centered care to date. I think we have a few thousand more to go, and it's a wonderful thing to be involved with because I have direct contact with staff when I do that. We address all new hires monthly. So there's a patient-family advisor there to ask those questions about patient-centered care. And I have the real thrill, I love it, it's such a power trip, of being the first to introduce patient-family-centered care. I'm the first person to speak to all new residents as they come to our hospital in July. And then I see them in clinics. And they say, "Do we know you?" And I say, "Be very afraid." You know, I'm not an adversary. I'm not an advocate. I want to partner with you. I want to walk that road with you and give you all the help I can, because I certainly expect a lot of help and support from you. Now, I won't keep you too much longer. You're probably saying, "Oh, well, she's done a horn and blown a horn and done this and done that. Where are they going now?" We're very conscious that we can't rest. We have to embed patient-centered care so fully into our system that it's independent of any few individuals. We're becoming an organization who's able to hear and act on criticism. Our patient satisfaction is up, but guess what? Our complaints are up. And I say yay because I think we're creating an atmosphere where people can say, "This went okay, and that didn't go well for me at all. I felt XYZ when that occurred, and I don't think I'm going to be punished for it." Yay. So one last thing that I find immensely exciting is patient-family feedback forums. So every unit in our hospital at least once quarterly, we'll have a session with a former patient, family member who has been treated on the unit, and that person will come back and have the chance to share his or her opportunity, an opportunity to share his or her experience with the people or the team that looked after them. And to do so in a non-accusatory manner, but to do so in a manner that we hope is helpful. Then the unit has the responsibility of taking that information and working with it. So I find that a very, very positive thing. I intend to have the last word, but Eleanor, you go ahead. I'm sure there are some more things you want to say. Just give me 2 minutes.
Yeah, 1 or 2. And I'm sure as you hear Andale and multiply Andale by 59 in our organization right now, and you begin to have a sense of the passion and the willingness that comes to the organization. When I realized it was a group of CEOs that I would be speaking to, I thought, okay, as a leader within our organization, what are the things that I really thought were the winning conditions to support this occurring? So I just want to share a few of those. One is I cannot understate the value of having a strategy that has been developed, a strategic plan that truly is a guiding tool to a document that isn't shelved, that is actually used every day, that staff understand, and that guides an annual plan for the organization every year. It absolutely has everybody sort of working in the same direction. And when your strategy says your goal is outstanding care always, and your first strategic direction is transforming the patient experience through a relentless focus on safety, quality, and service, and you know that you can garner the whole organization around that, you know that it's going to begin to have the change that we needed to make. So the strategy is clear. The importance of aligning all work and having clear accountabilities and alignment of those accountabilities and work to the strategy is key. It means that when you are assigning resources within the organization, it becomes clear the resources go to the work that is going to advance the strategy. And if you're embedding the voice of the patient and the perspective of the patient every step along the way, then again, you know that your direction is going to be pretty solidly in the right direction. There always needs to be the flexibility to course correct, but I think that alignment of accountability, alignment of resources, and the engagement along the way is key. The values that we have and principles that are articulated in our strategy are also key ways of defining how everybody in the organization is expected to work. And everybody in the organization means the staff that are hired, the staff that are credentialed, the advisors, the volunteers, anybody coming to be present for the patients. And those values are respect, transparency, accountability, engagement, and value for money. So I was pleased this morning hearing how all of those sort of affirm the work that is going on. We also learned that it's critical to be sure that as you say you're doing something, you need to demonstrate that you in fact are doing it. We were identified as an organization that was data rich. We probably had more data than, we knew we have more data than we can ever use. It was not being translated to information that actually informed changes that were necessary and being used in a meaningful way to measure it, to determine whether we were making those improvements. So with the input of the Patient Family Advisory Council or advisors at program levels, the organizational metrics, the quality improvement plan that's a requirement with our ministry, and all of the performance agreements that are signed within the organization have these expectations built into them. So again, it becomes a very strong link. I think it's important to appreciate this wasn't effortless. It does require resources, and it can't be done off the side of somebody's desk. But it does not require additional resources. It's where you need to look at what work is being done. We were spending an inordinate amount of time and a tremendous waste of money on doing things poorly. We reinvested and we redesigned. So, but the support that goes into supporting a patient advisory program is critical. not everybody was on board at the beginning. You can appreciate there'd be a lot of skepticism, and we get asked about particular groups, but I would say skepticism was throughout the organization and at every level. Nobody was immune to it. But what was so helpful is that we had champions who were real risk takers, who were change agents, who had the vision. And listening to Minister Horn this morning, they had endurance. And they felt strongly about it, and they weren't going to let it go. And what was also wonderful is that we had leaders who did not get in the way. We didn't have this all scripted at the outset. And Andale says, like, the advisory council started with advisors before there were any terms of reference for it. So people didn't get in the way of some of the work. And I think that's a really key learning. It didn't take long for people to recognize that this was the way it was going to happen. So, and I think that's a really important lesson again. If anybody thinks that patient family-centered care and patient engagement is the flavor of the month and this is going to disappear, I just don't believe it's so, and I haven't really encountered many who do. And with social media becoming the way it is, the voice of patients and the perspectives are going to become even stronger. So the partnerships are just so critical to us right now. There is no doubt in my mind that the advisors became the catalyst to the movement within our organization. They're objective. We've been really very deliberate saying, if they begin to talk like us all the time, then we're in trouble. You have to have a little bit of dissonance to be sure that it's authentic. But they do not come in with presumed conclusions. They come in and they're willing to learn with us and to teach us. And so the partnership is strong. What began as a journey of necessity for us, and I wouldn't recommend it to anybody, quite frankly, but it was a journey of necessity for us, has become a journey of choice. And we know that we weren't the first to move into this journey. We learned a lot from our colleagues in the States. We learned from different organizations in Canada. And we just thrill at the notion that there's sessions like this today and the opportunity that we are getting more and more to hear from organizations who are doing this in different ways, because that's where the rich exchange of knowledge is going to be key. The overall impact for us, I think, has been profound. Our culture within our organization has changed. Patients who came into our organization 4 years ago say when they come back in for whatever reason now, they can feel the change. Our staff talk about the change. We know the capacity for change within the organization is greater, and we have basically the equivalent of more than 2 full-time equivalents from our advisors alone, and I think that is grossly underestimated as an infusion of intelligence and energy. And we know our outcomes are better. Our performance improvement plan concluded last year. We balanced our budget. We had a capital budget that we could actually infuse into the organization, which had not existed for years and years. Our safety measures for patients were improving. Our turnover rates were decreasing. Our patient satisfaction rates, as Andale said, we were low. All of them are trending in the right direction, and we now handily exceed the Ontario Teaching Hospital average in terms of our overall patient satisfaction. So while our complaints go up, I interpret it much as Andale does, that we have a community that says, it's okay, actually. I'm not afraid now. I might have my concerns, but my fears are less. And so I think that we are far from done our journey, and it's far from perfect in our world, but we are definitely better than we were 4 years ago, and we are not as good as we will be at a system level or at an organization level 4 years from now. And as said, I usurped being the first voice this afternoon, so Andale is going to be the last voice.
May it be so, may it be so. I have to stand up when I say this because I used to teach and I don't feel comfortable sitting down. Just to leave you with a few messages for everyone in the room, and then one especially for CEOs. For all of you in the room, start small, start anywhere, just bloody start. CEO and senior management support is essential. without that real support, not interference, but without that real support, we're not going to get anywhere, really. We need the buy-in that's pushed through the senior administration till finally people begin to be converted. We all know, people have said here today, cultural change is complex. Think of your own lifetimes. It takes time to realize the benefits of cultural change, but never, ever, ever give up. You can drive change. You absolutely can. And as CEOs driving change, I would ask you to, or share with you the credo that we developed as patient advisors because we couldn't remember the long definition of patient-centered care. We translated it down into hear me, respect me, work with me. Je vous remercie.
Thank you so much, Ann Dale and Eleanor. It's a wonderful note on which to end, and since I'm sure you're going to be joining us for a glass of wine afterwards, people are going to have an opportunity to talk to you even more about this fantastic journey that KGH was sort of propelled onto for perhaps not the best of reasons, but nonetheless, you have more than proved the hypothesis behind this meeting, which is that patient and family-centered care is much more likely to lead to good care, integrated care, and indeed greater efficiency. So thank you ever so much. And it's well appreciated. And thanks to all of you for joining us today, and to the organizers on my own team, Linda Piazza and everyone else. It seemed at one point all of us was somehow or other arranged in organizing this particular meeting. I know that at our place every single person had an opinion on this meeting. And thanks also to Sally Clifford and Face to Face, our intrepid conference organizers who year after year provide wonderful service to all of us on the logistical side of this meeting. And most important of all, Terry Sullivan, who adeptly chaired this meeting and kept a light but effective managerial hand on our wonderful speakers. So thank you, Terry. Thank you to all the speakers, to all of you who have come. Un grand merci à tout le monde et merci encore Ann Dale et Eleanor. Alors, et maintenant, il ne faut jamais oublier l'évaluation. Alors, on dit toujours qu'on aide les organisations à évaluer, etc., mais c'est nécessaire pour vous de nous aider à évaluer cette séance, ces séances aujourd'hui. And after that, I'll be delighted to join you outside the doors for a glass of wine. Thank you, merci, voyagez bien.